Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, July 29th, 2024. Today we have a Mailbag podcast with me. What does the fox say? The questions I'm going to cover are related to transverse lie and ECV, taking a bath in pregnancy, sulcal tearing at delivery, DNC and preterm birth, placenta lakes, and two-vessel cords. Thank you to our terrific listeners, Jackie, Lindsay, Yufei, Simi, Aaron, and Stacy, for sending in those questions. All right, a few reminders. The Unexpected, which is the book I wrote with Emily Oster, is available wherever you buy books. Second, please do email us questions you might have for our upcoming Mailbag podcast. To send them in, you can email us directly at hw@healthfulwoman.com or go to our website and click on the link that says send us your questions. Please remember these questions are for the Mailbag podcast, not your own personal medical advice. For those, please ask your doctor. All right, next week we have a special treat. My wife, Dr. Michal Agus-Fox, joins me to talk about her decision to become a kidney donor. All right, thanks for listening. We'll see y'all next week with the more impressive and more awesome Dr. Fox. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Hey, welcome to Mailbag number 13. What does the fox say? All right, our first question today is from Jackie. Hi, Dr. Fox. Love your podcast. I have a question about positioning. I'm 31 weeks and my baby is still transverse. What are the odds that they'll flip at this point? Also, I was wondering if you could talk about the evidence on the safety of ECV procedures and other ways to get the baby to flip, e.g. spinning babies. I've seen a lot about breech babies and ECVs, but I wasn't sure if those stats still apply to transverse babies as well. Thank you for all that you do to help inform parents-to-be. All right, Jackie, thanks for the question. Okay, so a few things. First of all, it's totally normal at 31 weeks for the baby not to be head down. So again, for our listeners, transverse is when the baby's sort of lying across your belly. So let's say the head's on the right, butt's on the left, or vice versa. Breech is where the head is up and the butt is down, and vertex or cephalic is where the head is down and everything else is up. So at the time of delivery, we're hoping that the baby is head down. Nowadays, that's when we attempt vaginal deliveries. Nowadays, we don't deliver a lot of babies breech. If babies are transverse, they actually can't deliver vaginally because they don't fit that way. But what you were asking, Jackie, is about the safety and evidence for an ECV, which stands for external cephalic version. So we did have a full podcast on this, so everyone else can go to that for some background and some data on that. But your question specifically about transverse is, yes, the data about ECV in terms of the safety, the mechanics, what we do, all this stuff is the same whether the baby is breech or transverse. What I will say is the likelihood of success is probably higher if the baby is transverse compared to breech, which makes a lot of sense. We have less ground for the baby to cover, meaning if the baby's head is at, let's say, 9 o'clock on your belly, and we have to move the baby to head to 6 o'clock to down, that's less ground to cover than if the baby's head were at 12 o'clock pointing up. Another way to think about it, if you're not a clock person, right, if the baby's head is under your ribs, it's harder to flip the baby around than the baby's head is on your right side or left side. And so that just makes sense, but it's also true. It's easier for us to do the procedure, and it's more likely to be successful if the baby is transverse versus breech. Now, not always successful, but yeah. In terms of safety, I think it's safe either way. So it's hard to say that it's safer if the baby's transverse. But again, hard to really say because it's safe either way. In terms of other ways to get the baby to flip, and we discussed this in the full podcast on external cephalic version, the issue is none of them are really evidence-based, meaning there aren't good data supporting all the things you might find out there in Google, spinning babies or acupuncture or moxibustion, all these things. And so it doesn't, again, it's not that they're necessarily potentially dangerous. It's just many, many babies, probably the majority of them, are going to turn on their own to head down. So people who try other things, they're frequently going to work because even if you did nothing, they're frequently going to end up head down. But the only ones that have really been evaluated in rigorous scientific studies and shown to be helpful in getting the baby head down in a safe way is the ECV procedure. And so that's what's recommended. Okay, so for 31 weeks, so I know when you wrote this question, you were 31 weeks and you probably delivered by now, but hopefully the baby turned on its own, which is the most likely. And if not, hopefully you were offered an ECV procedure and it was done and it was successful and you delivered vaginally. But if not, and you had a healthy cesarean, of course, that's fine too. Hope all's well. Thanks for the question. All right, the next question is from Lindsay. Hi, Dr. Fox. Toaster here. Smiley face emoji. What are your thoughts on a bath in pregnancy? 98 to 100 degrees is just too chilly to be enjoyable to me. Pre-pregnancy, I loved a good 102 to 103 degree bath. Is it a terrible idea to take even a short 10-minute 102 degree bath as long as I'm not sweating, getting red, or feeling faint? Thanks in advance. Appreciate your opinion. And thank you for this great podcast. I've loved listening during pregnancy. Thank you, Lindsay, for the kind words. Thank you for the question. Okay. So where does this all come from? There is a thought and a concept that it is not good in the first trimester of pregnancy to have a very high body temperature, like a fever, right? If your core body temperature is high, above normal, that might have an impact on the baby's development of either the organs or most specifically the brain. And so that's why when someone has a fever in the first trimester, again, we recommend taking Tylenol, whether you need antibiotics or not, depends on the circumstance, to lowering the temperature. Now, it's not that everyone who has a fever or high temperature, it's going to cause a problem to the baby, but that's a concern. Okay. So then there was an extrapolation to that. Well, maybe because of that, we shouldn't recommend hot tubs or saunas in the first trimester. And there is some data on that. It's a little bit mixed. It's not perfect. There's some data that suggests a slightly higher risk of miscarriage for people who go in saunas and hot tubs in the first trimester. Again, it's not clear if it's real or if it's just a function of the study design, where sometimes when people miscarry and then retrospectively ask them, like, did you use a hot tub or sauna? They go, oh yeah, I did. And sort of, it could just be like, so we call bias in the study, that maybe it's not a real cause and effect, but you sort of see it in certain studies. And because of that, there are some loose recommendations about avoiding hot tubs and saunas in the first trimester. I call them loose because it's not entirely clear that it's actually a problem, but maybe. Fine. So does that extrapolate to a bath, right? So be like, well, if I can't be in a hot tub, why can't I be in a bath? And what I would say is there really is no good data on this. And I would say, so it's hard to give a definitive answer, but my gut is that it's not an issue for several reasons. And this is what I tell people. Number one, people have been bathing for a very, very long time, right? And you would think that we'd sort of sort out by now if baths cause problems in pregnancy. And so it does not appear that they do. Number two, a bath is different from a hot tub because a hot tub is actually heated internally. So when you get in the hot tub, the temperature of the hot tub does not go down because it's continuously heated to a certain temperature, whatever that is. Whereas if you go in a bath, right, you put in a bath of hot water, whatever temperature it is, when you get in, the temperature of the water is dropping. It's not maintained at a certain temperature. That's number one. Number two, it doesn't necessarily raise your own core body temperature for that same reason. Number three, it's not entirely clear that your core body temperature is higher when you take a bath versus if you take a hot shower. Again, what if you live and it's 102 degrees outside? Is your core body temperature going to go up by the same degree? Not necessarily. So I don't typically tell people they need to avoid baths when they're pregnant. Again, all of this is just first trimester. Certainly, second and third trimester doesn't seem to be an issue. People take baths all the time in terms of their own relaxation or sometimes for pain, when in early labor and whatnot. People deliver in baths, if it's available. It's really just an issue potentially in the first trimester, and I don't tend to have an issue with it. Typically, I'm kind of mixed on hot tubs most people are fine avoiding it in the first trimester, just that they want to be extra cautious. But for baths, I don't tell people that they have to avoid taking a bath in the first trimester. And there's really no data to suggest that it causes any issues. Okay, next pregnancy is from Yufei. I hope I'm pronouncing that correctly. Hi, Dr. Fox. Can you talk about sulcal tearing? My first pregnancy culminated with a sunny side up baby, vacuum delivery, and internal tears in the vagina. The vaginal tissue was too friable for stitching, and the OB had to use gauze packing to stop the substantial bleeding. The tears ended up getting infected, which resulted in a return trip to the OR, the big one, not labor and delivery, 3 days postpartum, and months of painful recovery. Is it common to have serious complications from sulcal tears? Would these complications be enough for you to recommend an elective C-section for my second pregnancy? Thanks, Yofei. So, good question. I'm going to give some background for our listeners who might not understand everything you were talking about. Okay, so when babies are born, very, very frequently, the majority of the time, certainly on a first baby, there is some amount of tearing that occurs. And that occurs naturally when the baby's head comes out, or it could possibly happen due to an episiotomy where we actually make the cut. And again, we've had podcasts on this, episiotomies, no episiotomies, tearing, no tearing. But basically, many, many people, certainly the majority, are going to have some amount of tearing. And we're going to talk about natural tearing for now. Typically, the tearing that occurs, where is it? Like, where are we talking about here? So usually there's some tearing inside the vagina towards the outside, what we call medically the distal, like the outer portion of the vagina. So if we were sort of examining, looking in, just sort of the outer portion, a few centimeters, few inches, whatever that is. And then typically it'll tear down into what we call the perineum, which is sort of that skin area between the bottom of the vagina and the top of the rectum. So usually there's sort of two portions that get put together. One is the vagina itself, the outermost portion of it, and then the perineum. And that's a typical tear. And we grade them first degree, second degree, third degree, fourth degree based on how deep it goes. The most common is first degree, which is just more like the surface, and then second degree, which is the most common. Then third degree and fourth degree is where it goes so deep that it involves the sphincter, the muscle around the anus, around the rectum. Okay. Some people, and this is where we get to your question, have what we call sulcal tearing, S-U-L-C-U-L. It's essentially where it goes higher up in the vagina, like up the side of the vagina, almost, it can go all the way to the top, like near where the cervix is. That tearing is a little bit less common, but absolutely can happen. When it happens, it's a little bit more challenging for us to repair it because we're sewing like in a tube and we have to get very high up in order to repair it. And sometimes there is bleeding from there, obviously, and sometimes either it's too difficult to repair entirely or there's bleeding from it. And then one of the ways we treat it is, as you had, putting a packing inside the vagina, like filling it with either gauze or towels or whatever it is, like inside that tube that puts pressure on the outer walls of that tube where this tearing is. And sort of that's temporizing. You do that for 6 to 12 hours. And with pressure, the bleeding just stops. And then when you take out all of the gauze, the towels, whatever the packing was there, that pressure plus the stitches you placed in is going to have the bleeding stop. And then over time, that tissue does heal. It is unusual for it to get infected, but it can, which you had. It's unusual to require a return trip to the operating room to fix, but that can happen. Sometimes, we just put in the packing to sort of get things stable, stop the bleeding, and then we know that there's a possibility we'll have to go back to the operating room to repair it properly. And so what happened to you does happen. It's not that common, but it does happen. Usually, interestingly, those tears, anything sort of inside the vagina tends to heal very, very quickly and very, very well. And those types of tears don't tend to open up again in the next delivery. The tissue tends to stretch, meaning when people have like third or fourth degree lacerations, that's sort of more on the perineum side, sort of towards your bottom. It's a thicker tissue. In the next pregnancy, it can open again, though usually doesn't. But typically, when we're talking about C-section for the next birth, it's usually if someone's had a fourth degree tear, that it went all the way through the sphincter around their bottom, and we had to sew the rectum, and The fear is that if that healed nicely, you don't want it to open up again and risk it not healing so nicely and people having issues with, gas and holding in their stool, which is obviously very, very, very disturbing to people for good reason. But the tears that are inside the vagina tend to heal very, very well, usually do not open up. And it's not a typical reason we would recommend a C-section in the next pregnancy, because usually the delivery goes much smoother and there's less tearing. Now, with that said, obviously, anyone whose delivery and tearing and repair and recovery and whatever it is was very difficult for them, traumatic for them, whatever it might be, might want to opt for a C-section in the next pregnancy. And that's a very individualized decision based on sort of what risks are you willing to take, not willing to take, what kind of recovery you're looking for or not. And so that's fine. It's totally reasonable to have a discussion with your doctor about doing a C-section next time. But I would say it's not typically something that we would bring up and say, okay, since you had this kind of tearing, you should probably have a C-section next pregnancy. That's not something we would typically say. We would say, wow, that's a tough delivery, tough recovery. Next time around probably should go a lot better in terms of sort of what to expect for the next pregnancy. So I hope that answered your question. I hope you recovered nicely eventually from that difficult delivery. Oh, one other thing I ought to mention. So one of the big risk factors for sulcal tearing is having an operative delivery like forceps, but it absolutely can happen without that. So we just see it in some people. Again, we don't really understand why it happened in some people versus somebody else. Sulcal tearing is one of the things that possibly an episiotomy could actually avoid. One of the thoughts of an episiotomy, or one of the good reasons to do an episiotomy, is if I think someone's going to have very big tearing in other places and I can do one episiotomy in a specific place and just have to repair that, maybe that's better than having multiple tears. Now there's obviously a lot of experience and art that comes into knowing when that's going to happen and when to do it, but that's sort of the thought process. But it absolutely can happen like you had without necessarily, you had a vacuum delivery, but without forceps delivery. So it's a risk factor, but it can happen to anybody. Okay, next question is from Simi, and it's related to a DNC. Hey, awesome podcast this week. Absolutely brilliant and loved it. This was written a few months ago, so I'm not sure exactly which podcast, but thank you. Also wondering if you'd be open to discussing the following in your Mailbag podcast. Is there any correlation between DNCs and subsequent preterm birth? Meaning, prior to having a DNC for a miscarriage, they had a regular full-term birth or births, and since they had a DNC, all their subsequent births were preterm. I mean, obviously DNCs are important and they should not or could not be avoided in some situations, but is it possible that DNCs can contribute to some kind of preterm birth cause? I've heard a couple people who claim that's what happened. I'm wondering if there's anything to it. All the best, Simi. So really good question. This comes up a lot. So again, for some background, a D and C stands for dilation and curettage. It's basically the procedure that's done in the first trimester for someone who's having, let's say, a miscarriage and is bleeding, or has retained tissue from a miscarriage, or if someone's having an elective termination of pregnancy or any termination of pregnancy. And what it means is the dilation portion is we're taking dilators and we're sort of slowly dilating the cervix from a closed status to, let's say, maybe a centimeter dilated. And curettage is based on the instrument that used to be used all the time, where you sort of curette or scrape the inside of the uterus. Nowadays, most of them are done with a suction, so it's called dilation and aspiration, so D and A, although people use the term DNC all the time, even though there's no curetting, they use an aspirator. It's sort of traditionally called a DNC. And the question is, okay, is doing that procedure, and the thought is maybe dilating the cervix, is that going to cause some damage to the cervix that'll then lead to an increased risk of preterm birth and a following pregnancy, presumably because of a weak cervix, cervical insufficiency? And I would say that most of the data supports the fact that generally no, meaning for the vast majority of people who have DNCs in the first trimester, it's not going to cause any damage to the cervix or insufficiency or incompetence, whatever word people use, to the cervix, and lead to preterm birth. There is some evidence that maybe if someone has it in the second trimester, now in the second trimester, we usually call it a D and E. Again, dilation and the E is either extraction or evacuation. It just indicates that the pregnancy is more further advanced, the fetus is larger, and you have to dilate the cervix more. So instead of dilating to, let's say, 1 centimeter dilated, like a fingertip, you have to dilate it to 2 or 3 centimeters dilated. And there is some data that people who have that procedure in the second trimester might have an increased risk of cervical, let's call it cervical damage, or not really, but some reason that cervix is not as sufficient and has a higher risk of preterm birth and following in future pregnancies. All of this is complicated data for a lot of reasons. First of all, the vast majority of people who have any of these procedures are not going to have preterm birth in their following deliveries. So whether you have this or don't have this, whether you have a first trimester or second trimester, the overwhelming likelihood is it's not going to affect your cervix and it's not going to affect your future pregnancies, number one. Number two, people can't typically just randomly choose to have one of these procedures, right? It's usually because there's something going on. There's a miscarriage or whatnot. And if you could potentially devise a study where you randomly choose people to have a D&E, but the alternative is something else to dilate the cervix and empty the uterus, whether it's medication or whatnot, or labor. And so it's hard to sort of say that it's specifically from the procedure that does this, and it's very unusual, and those studies don't tend to be randomized. So what I would say is the data on this is mixed, not entirely clear, and for the most part, what I would say is for first trimester D&Cs, there does not appear to be a link with that and preterm birth. There are maybe some exceptions that people have multiple D&Cs, but then it might not be necessarily the procedure itself, but why are they having multiple miscarriages, right? It could be like similar risk factors, so to speak, that it's not the procedure, but maybe the risk factors. Second trimester, there's a little bit more data that suggests it might lead to an issue with the cervix, but again, that's a might, and it's not going to happen in the vast majority of people. It's pretty unusual across the board. And like you said, D&Cs, D&Es, these are important procedures that people have for a reason. And so typically when we're counseling people about this procedure and we're comparing it to the alternative, we don't typically put too much stock in, if you have it this way, you have a higher chance of preterm birth. And if you have it this way, you don't have a higher chance of preterm birth, because that's not known to be true. Great question, complicated topic. Hope I was able to answer that for you as best as possible. Okay, next question. We're moving on. Last two questions are going to be related to the placenta and cord. Okay, Aaron has a question about placenta lakes. Hey, Dr. Fox, love the podcast. Heard about you and your show from the Toast. Love the Toasters. My question is about placenta lakes and placenta abruption. At my anatomy scan, they found either a placenta lake or beginning stages of abruption. They couldn't give me a clear answer and just said extra monitoring is needed because they couldn't quite determine what they saw. I'm not bleeding, feel good, all that jazz. Can you explain more about placenta lakes, placenta abruption, and if I should be concerned? All right, Aaron, great question. Yes, this is a confusing topic. Now, placenta lakes are something we see on ultrasound during pregnancy. We could see it, usually we refer to them in the second and third trimester. The best way to describe it is they're basically spaces in the placenta that are filled just with maternal blood, meaning not the spongy part of the placenta, but just the maternal blood. Now, there's always spaces in the placenta for maternal blood, right? The placenta is basically the spot where there's maternal blood flowing sort of within it, and then there's fetal blood coming in there through vessels. And the goal of the placenta is to get the fetal blood vessel very, very, very close to the maternal blood so that you can have things like transport and diffusion. So oxygen can go from the mother to the baby's blood. Things like carbon dioxide and waste product can go from the baby to the mother. Nutrients, all this stuff. So you want the bloods right near each other. So the way the placenta is built is it has this sort of spongy parts we call the cotyledons. And in between them, there's these spaces, the intervillous space, which is basically just these pools of the mother's blood that basically sit there in the placenta. So a placenta lake is basically when we see that and it's a little bit enlarged compared to normal. And they are noticeable on ultrasound because they are black, right? Blood on ultrasound looks like water, looks black, whereas the placenta tissue itself looks gray. So you see these sort of black circles in the placenta, number one. Number two, if we look closely, we can see sort of blood like floating around or swirling in there because it's just sort of like sitting and splashing around, but it's not a blood vessel where we see like flow, like where it's actually like moving like in a pipe. It's just sort of hanging out there. And they're generally considered to be normal findings. You're supposed to see them in placenta. So most of the time, they mean nothing. However, there are certain times, like if we see more than usual, a bunch of them, they can be associated with a problem in the placenta, or very, very large ones, very large placenta lakes sometimes can be associated with issues. And again, these are kind of loose associations. So when we see either multiple ones or very large ones, we tell people probably means nothing, but we'll just keep an eye to make sure that the baby's growing well. The reason we check that the baby's growing well is the fear is if it's a concern with the placental function, the main function of the placenta is, there's many, but the main one is to feed the baby nutrients, oxygen, water, and whatnot. So we just make sure the baby's growing well to know that however the placenta looks, at least it's functioning fine. Now, there are sometimes, so that's what a placental lake is, that's what it is, and generally means nothing. Sometimes we just need to follow a little bit closely. There are sometimes things that are called placental lakes, but probably are not. So sometimes you see these black circles, instead of within the placenta, you see them between the placenta and the uterus. That is more accurately called a subchorionic hematoma, where there's a collection of blood behind the placenta. And that has different implications because it's not really within the placenta, it's between the placenta and the uterus. And the thought is that there is some either bleeding that happened behind the placenta or a small piece of the placenta is separated. And again, we had a podcast on this. Most of the time, particularly in the first trimester, it doesn't appear to mean that much. Sometimes in the second or third trimester, they're a little bit more concerning, especially based on the size. And the reason your doctors maybe mention placental abruption is that a placental abruption is where the placenta separates from the uterus, and then there's bleeding and contractions and possibly preterm birth and all this other stuff. So the thought is if they see this blood collection behind the placenta, maybe it's like an unrecognized small placenta abruption, again, that hasn't had any bleeding, and they're a little bit concerned. And that's, how to tell the difference between a lake and that, just requires some skills, some pictures. I guess if it's confusing, maybe it's like right near there and they're not sure if it's a lake towards the end of the placenta versus a hematoma behind the placenta. And so I guess there can be times when it's not obvious which one it is. Either way, ultimately, when you see things like this, and again, otherwise everything looks fine on ultrasound, the placenta otherwise looks fine, and the baby looks fine, everything looks healthy, generally it's just a sign that we may or may not need to watch you a little bit more closely, like they said, to see how the baby's growing. But otherwise, we don't really do much about it. There are other circumstances when someone's at risk for something called placenta accreta, which we talked about a lot of times in prior podcasts. One of the ultrasound signs of placenta accreta is a placenta with many, many lakes in it, for example. So if someone's at high risk for placenta accreta and we see many, many lakes, that might be one potential concern. If you see it without risk factors, placenta accreta, what does that mean? Again, it depends on the circumstances. In each case is unique, but just seeing one or two or one that's larger than normal usually means nothing. Sometimes means we have to watch you a little bit closer. Last question related to the placenta and cord is from Stacy. Hi, I'm a patient in your practice and loving my experience so far. Every doctor I've met with has been excellent. Stacy, thank you for the plug. I am pregnant with number 2 and was just diagnosed with a 2-vessel umbilical cord. I'd love to learn more about this and what outcomes you generally see. Well, Stacy, fortunately, I'm sure our doctor has explained it well. Number 2, we did do a podcast on this, so there is a reference for you as well. But just for our listeners and as a brief review about 2-vessel cords. Okay, so the umbilical cord, which is what connects the placenta to the baby, generally has 3 blood vessels in it. It has 1 vein, and the vein is what brings blood from the placenta to the baby. Now, it's not maternal blood, it's the baby's blood, but it's sort of the baby's blood that went to the placenta. And as we talked about in the last question, how the baby's blood goes to the placenta, it gets all its oxygen and nutrients, and it comes back to the baby. So it returns in the vein and is 2 umbilical arteries, which are the blood vessels that go from the baby to the placenta. So in a typical sort of circuit. There's the baby's heart pumps, and when it pumps, there's blood that flows out the umbilical cord, out the two umbilical arteries towards the placenta. Then the blood hangs out in the placenta, gets nutrients, relieves whatever needs to come out, and then it comes back into the baby via the umbilical vein. So that's what typically happens. Every now and again, probably, 1, 2, or 3% of the time, when we're looking on ultrasound and we look in the umbilical cord, we see that in fact, instead of 3 blood vessels, there are 2 blood vessels, 1 vein and 2 arteries. The baby couldn't live if it was 2 arteries and no vein, so it's always 1 vein and 1 artery. And so it's quote unquote abnormal, but it's really more of a variant of normal because it's typically not a problem. So the answer to what outcomes do we generally see? We generally see that everything is fine with everybody. So what are we potentially concerned about? So it's not an issue of like plumbing mechanics, that there's not enough blood vessels to take blood from the baby to the placenta. That's not really the issue. The question is, when you have an umbilical cord that formed quote unquote abnormally, right? 2 vessels instead of 3, does that mean that it's a sign that there's abnormalities elsewhere? That's really the point. When we see a 2-vessel cord, having a 2-vessel cord itself is not problematic. It's whether it indicates that there's something abnormal elsewhere. So where else could it be? The first place we would think is maybe the placenta, right? The placenta and the cord develop together. So the fear or the potential concern is that if there's an abnormality in the cord, maybe there's an abnormality in the placenta. So not one that we can see, but maybe one with the function of the placenta. So when we see a 2-vessel umbilical cord, one of the things we do, if we were not already doing this, is instead of saying goodbye to you after the anatomy ultrasound, we basically do some form of monitoring that the baby is growing well, because that's the main purpose of the placenta. So whether that means an ultrasound every month, every 6 weeks, every 8 weeks, whatever it is, different people do it differently. In our practice, typically every month, we just do an ultrasound, bring in, make sure the baby's growing well. And if the baby's growing well, we know that the placenta is at least functioning to the point that's giving the baby nutrients. So that's sort of the way we assess that the placenta is functioning well, that the baby's growing, good nutrients. So that's number one. The second thing is, and this is probably true statistically, but we don't see a lot of it, is that the baby's heart also develops from a blood vessel. And so the thought is, if something wonky happened with the blood vessels in the cord, maybe potentially there's an increased risk of an abnormality in the baby's heart because it also developed from a blood vessel. And I would say statistically that is true. People with 2-vessel cords are more likely to have a baby with a heart abnormality. However, typically when we diagnose the 2-vessel cord, we are at the same day looking at the baby's heart. And if the baby's heart looks normal at that time, it's very unlikely that there's some mysterious heart defect happening that we haven't seen. Now, with that said, we are always very cautious and we make sure to do a detailed anatomical ultrasound of the heart. We usually recommend a fetal echocardiogram, especially if we couldn't get all the views of the heart. But assuming those are normal and the baby's heart looks normal, we don't have a lot of concern that something is going to surprise us after birth with the baby's heart. And we don't typically see that. If everything looks normal with the heart is almost certainly going to be normal, which is true with everybody, basically, right? We never give anyone 100% guarantee when we do an ultrasound that since it's normal, everything's going to be perfect. But basically, as reassured as you can be from an ultrasound in the second trimester that the heart's normal, that's very, very reassuring. And that's basically what we do if there's a 2-vessel cord. Again, we follow to make sure the baby's growing and we do the echocardiogram. Now, once the baby is born and we clamp that cord and cut it, it doesn't matter how many vessels are in the cord because those blood vessels inside the baby all go away after birth. They turn into ligaments. So it's not something that has any impact on the baby after birth. It's really only up until birth. And again, in the vast majority of the time, it means nothing. Now, there are some places on the Google where it might tell you that having a 2-vessel umbilical cord is associated with genetic abnormalities in the baby. Now, it's not necessarily false, but it's a little bit misleading. And the reason is, yes, babies who have genetic abnormalities are more likely to have a 2-vessel cord, or babies with 2-vessel cords are more likely to have genetic abnormalities. But if all you see is a 2-vessel cord, meaning all the testing is normal and the baby otherwise looks normal, then it does not appear that having just a 2-vessel cord increases the risk of a genetic abnormality. If I saw a 2-vessel cord plus something else, plus something else, plus something else, yes, that might be more suspicious for genetic abnormality. But if I see a normal appearing baby and you've had normal testing and the only thing that's quote unquote off is a 2-vessel cord instead of a 3, we do not typically counsel that there's an increased risk of a genetic abnormality. So that is reassuring. All right. Another great set of questions for this mailbag. Thank you all for sending them in. Keep doing so. Have a great week. Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.